The sudden outbreak of COVID-19 has exposed the long-drawn neglection of healthcare sector in India. This underfunded sector is suffering from deficient infrastructure in the form of lack of well-equipped medical institutes, a severe shortage of well-trained manpower, including doctors, nurses, paramedics, and primary healthcare workers. Therefore, government has taken lessons from its failures and thereby launched schemes and programs like Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, Digital Health Mission, One Health, One Nation to achieve universal health care. Moreover, people are also adopting to the newly emerging trends like genomics, telemedicine, digital prescriptions, and many more. But it seems that there is a long way ahead, and to guide us through this long journey, we have with us Mrs. Preeti Sudan, former Health Secretary of India. Madam is an 83 batch IAS officer of Andhra Carter. Apart from this, she has served at various central and state level positions like Joint Secretary in Ministry of Defence, as well as in positions relating to disaster management and tourism. She has been the key functionary in planning and implementation of Ayushman Bharat mission. She has served as a consultant to the World Bank at Washington and was appointed as a member of independent panel for pandemic preparedness in July 2020. We wholeheartedly welcome you, ma'am. The session will be moderated by Soham Agarwal and Shashutya. Thank you.
Good afternoon. We are inspired by your work as the former Health Secretary, ma'am. Ma'am's tenure saw the rolling out of Ayushman Bharat and India's fight against COVID-19. Humanity's struggle for with death has been greatly aided by medical advancements, but accessibility has to be the longest living problem of them all, greatly ameliorated by policy intervention like Ayushman Bharat. And that is what we're here to discuss with ma'am today, healthcare in the post-pandemic era. Ma'am, as the key person behind India's fight against COVID-19, you have seen administrative challenges and ground realities closer than most. Ma'am, what were some of the unique challenges you faced? How were they overcome? And what could have been done differently? Because these are some experiences we can learn from events. Thank you, ma'am.
So, good afternoon to all of you. I'm just wondering कि तुम्हारी lunch break नहीं होती क्या? So I find some people have left maybe for a bite. But anyway, so let me begin from the beginning. See, I have also written an op-ed on my learnings from COVID. First of all, I would like to say that the experience taught me to talk less and listen more, and also taught me humility, because there were numerous people all over the country, risking their lives to save all of us. The nurses, the doctors, the frontline workers. So let me begin by saying that we owe a lot of gratitude as a nation to them. And next is that if I say what was the policy principle, then you will understand how we went about it. You see, our COVID policy was proactive, preemptive and graded. Why I am saying that is, on January 8th, when we had a first meeting of experts, this was a meeting which Health Secretary did not know about, but the doctor, the director EMR, Emergency Response, he convened this meeting with the Director Health Services to understand what was happening in China, because WHO had just said that there is a virus spreading, but they did not say that it had human to human transmission. And it was this particular, I would say, delay in declaring human to human transmission, because they did it on 24th of January. Already on 16th, cases from Wuhan had spread to Thailand, to Japan and other areas. So what I want to insist is that we learned on the way. You asked for challenges. Let me tell you something very interesting. When Dr. Balram Bhargav, the DG ICMR, and I sat down to take stock, we had just 6,000 kits of tests, RT-PCR tests. And NIV was the only, Pune was the only lab we had. So, and the probes and the reagents for these tests were imported. We did not have stock of cloth for PPEs because we stitched it ourselves here, but the cloth came from China. N95 masks has a respirator inside. That respirator is also imported. This was our condition. But today, we are exporting PPEs, we are exporting N95 masks, we are also exporting test kits. So, you see, the challenge was turned into an opportunity. And again, when I started to answer you, I said it is gratitude. Gratitude to the great, that everybody got together to meet this challenge. So it was a whole of government approach. The textiles department, the textiles industry, our epidemiologists, our researchers. So now we don't need to actually import any of this to manufacture. We actually do it ourselves. But you see, in the initial days, we had to ration PPEs. And tests, we actually quickly we imported some initially from Germany as long as it was open. And then we found in March, so sab kuch band ho gaya tha. So then we had by that time started making our own. And true for respirators, true for all the essential supplies that we need for this. Then next thing is that, we use technology. So, as you know, even in the initial days, the test reports were available online on the ICMR portal for all to see. So there was no fudging, there was no, inconsistency in reporting. The reports were there. Next is that we actually came up with that Arogya Setu app. So we used real-time monitoring of the cases. So contact tracing was also done through technology. Then we also used actually, we did analysis of hotspots along with IIT. We were able to use the telephone data with the, I would say, telephone poles that to find out where the person is. So we could also sort of gather that what will be the next hotspot. So much of technology was used. And of course you was asking what were the lessons. The main lesson was that we need to invest in health. So we need to invest in infrastructure, in human resources, in collaborative research, in also, when I say collaborative research, it is not only for, say, the future viruses that could come, but also for medicines. And of course, I must put on record that the way our Indian manufacturers have come up with indigenous vaccines. And let me tell you, I am on the international panel for pandemic preparedness and response. There has been so much international inequity in vaccines. The panel has been requesting the developed nations to part with their stockpiles. They did not do it initially. Now some of them have started. Let me tell you that how selfishness comes in. The US and Europe, they gave orders for 4.3 billion vaccine doses. Their population together is 1 billion. So even if 2 doses are taken, they still have 2 billion doses in surplus. They were not ready to part it. So this is the kind of nationalist selfishness had come in. But India actually did sort of, I think, very well in being independent of this kind of import. We had our own vaccines, and there were challenges also. For example, mRNA vaccine needs a cold chain of -23 degrees centigrade, which African countries don't have, which we don't have. We have up to -8, and we have a very beautiful, robust, I would say, vaccine, cold chain arrangement. So with our own indigenous vaccines, we could cope with that. So that's a good story. But you were saying, so as I was saying, we have to invest in collaborative research. We have to also invest in wellness now, because we've always been talking about curative care. Health is not absence of disease, it's also wellness. So I think that's what we have learned, and that's what we are doing. So a lesson, you may have heard of this, Prime Minister's Ayushman Bharat infrastructure mission, wherein some 64,000 crores has been given, where every hospital will now have a lab. Every district hospital will have its own oxygen plant. So every district will have what is called critical care beds, including our tertiary care, so it's a massive program where infrastructure robustness is kept in mind, not only in metros but also in rural areas. So I think that's the way forward.
Ma'am, India not only achieved its set target of 1.1 lakh health and wellness centers as on 31st March 2022, but we overachieved, which is truly a remarkable achievement. Ma'am, can you tell us what goes behind the setting up of a single health and wellness center, and what are the areas this health and wellness center targets primarily?
Health is a paradigm which has to be inclusive of primary health care, secondary health care, tertiary care. So we need to cover everything. So under Ayushman Bharat, that's what we did. And let me ask you a question, that in your family, in the last, say, take pre-COVID era, not now, how many of your relatives have been hospitalized? One. So, I had this fortune of dealing with Arogyashri scheme of United Andhra Pradesh for almost 10 years as finance secretary in the state. And we found that not even 1% of the population actually goes to hospital. So we had the insurance model where hospitalization expenses were actually reimbursed. So, which means, but this expenditure is catastrophic expenditure. तो अगर गरीब का कोई हॉस्पिटल जाता है तो the family falls notches as far as poverty line is concerned. So it is catastrophic. Therefore, PMJ, Pradhan Mantri Jan Arogya Yojana, it covers actually 40% of the poorest. So it meets their expenditure, 50 crore population, 5 lakh per family per year is reimbursed. It's cashless, so there's no reimbursement to the person, it's reimbursement to the hospital. He doesn't have to spend money. So I think that's a great safety net for the poorest. Now when we designed Ayushman Bharat Health and Wellness Centers, as I said, 1% say go to, but 99% need to visit a health facility, multiple times in a year. Abhi kabhi zukam ho gaya, khansi ho gayi, malaria, TB, something or the other, you need medicines, you need all this. So you already had actually about, I would say, 25,000 primary healthcare centers and another about 1.5 lakh sub-centers. But though the primary healthcare center did have a medical officer, the sub-center had only a ANM. So you see, what services were given there? Basically, maternal health, child care, and also free immunization and some medicines. That's what it was. But when we designed health and wellness centers, there were two fundamental principles. First principle was that health and wellness centers will now dispense promotive and preventive health care. The multi-sectoral paradigm of wellness was recognized. Therefore, and next was that this package of services will be expanded. So I'm not saying that there are 12 packages actually. So, maternal care, child care, immunization, then NCD screening, non-communicable disease screening. Now we are doing in these health and wellness centers, which means that, the आशाs, आशा तो समझते हो ना, गाँव में जो आशा दीदी होती है, जो volunteer है, and who gets paid as per her work done. So for every visit, says she gets 100 rupees, 50 rupees, depends on the state. So they did what is called CBS, Community-Based Survey, where we had designed that. That is there on the web or net also if you see. तो उसमें क्या क्वेश्चन पूछा कि आपके घर में किसी को सिर दर्द होता है, होता ही रहता है, या प्यास लगती रहती है, या फिर आपको you have some menstruation problem, you have bleeding, does anybody chew tobacco, does anybody smoke? So then we started doing ये सब करके identified population of the village who would need screening for non-communicable diseases, 5. Hypertension, diabetes, and 3 cancers. The 3 cancers are cervical cancer, breast cancer, and oral cancer. So as of today, you said 1.17 lakh we have already achieved. We had to do just 1 lakh. इसमें 85.87 crore footfalls. Because पहले तो लोग जाते नहीं थे. Footfalls means people have visited. These centers people have visited up to March 31st. We have done screening for 17 crore for hypertension. We have done for diabetes 12 crore screenings. We have done another 17 crore for 3 cancers with 9.7 crore for oral cancer. So what I'm trying to say is that this paradigm of preventive care is unique to India. It's there in Sweden also, incidentally. It is unique to India, and in a country like ours with our population, I think we really need to be very proud that the government is thinking of wellness in health. Then you have these wellness sessions. So you have yoga, about 1 crore have been conducted up to March. So why I'm giving you these figures is because it's very important to understand the magnitude of the effort that is taking place there. Then another thing is that I said, we have to access, and also what was the reason? You see, if your health center is not within say 10 to 15 kilometers of your place, women will not have access. Women will not be taken. So I had this fortune, I would say. I went to villages, I saw ये जो NCD की हम स्क्रीनिंग कर रहे थे, वहाँ पे middle aged women, old women, coming and saying सिर दर्द होता है, मतलब BP है, that kind of thing. So it was most fulfilling to see that now they are getting access. नहीं तो उनको कौन अस्पताल लेके जाता? So therefore, I would say that this health and wellness centers is something which is remarkable, but I would also like to add, though in the rural areas it has taken off, in urban areas we need to put in more effort. Because you see, in urban areas the governance structures are different. कहीं municipality है, कहीं municipal commissionerate है, कहीं पे तुम आपका अभी पंचायत ही है, and then we don't have these ashas to do, and community is not homogeneous, there is migrant labor, so there the effort has to be still, I would say, to be made more.
थैंक यू मैम। मैम क्या आपको लगता है ये पैंडेमिक प्रिपेयर्डनेस में हेल्प करेगा?
करेगा नहीं, करा है। So let me tell you, we had started this in 2018. I wrote an op-ed on this 2 days back also, on the 14th of April, which was the 4th anniversary of health and wellness centers. The first health and wellness center was set up in Jangla, in Bujapur, in Chhattisgarh district. I remember going there. My God, to reach that place also was so difficult. But you see, so we had started screening, and we had about 50,000 ke kareeb, I would say, centers by then, by the time COVID started. So we had this data of who had these issues in the villages. This data is with the states. So you see, it helped people in 2 ways. People with comorbidities needed attention, both for vaccine and also for treatment, number 1. Number 2, they needed their medicines. They needed BP ke medicine, sugar ke medicine to roz khani hai. So those medicines were also provided. And then you see, there was a watch over people who had these comorbidities. So with an ambulance they were linked also if they had COVID to the center, where isolation centers or to the treatment centers that were. So this has helped. And secondly, because hospitals were not taking OPD, so through telemedicine, we have actually dispensed also, especially in primary health care centers, I would say consultation for कि मुझे बुखार हो गया, ज़ुकाम हो गया, सिर दर्द हो रहा है, अभी यहाँ टांगों में दर्द हो रहा है, या TB का इशू हो गया. Even AIDS medicines were given to people in their houses. So all this has definitely helped, I would say. And let me also say that during this critical time, we had a software called eSanjeevani, which was an e-learning software made by CDAC of Ministry of IT, MIT as we call it. They are based in Mohali. So they had made this software for us. We had linked 53 medical colleges for peer learning. So when this came, we quickly, CDAC actually customized this software for telemedicine. So the whole nation, at least in the public sector, is using this software. So lots of things happened very, very quickly, I would say. I think India is very great in handling emergencies. So, of course, there was a lot of suffering for people, lot of, as we know, there's another scare now, अब cases पे ऊपर हो रहे हैं, हम सब बिना मास्क के बैठे हैं यहाँ पे. As former health secretary, I should also not be doing so. And but the point is that we are in the right direction. That's what I would like to say.
Thank you for your response, ma'am. Ma'am, one thing I want to ask is the announcement in the recent budget of setting up the national digital health ecosystem. Ma'am, my question is, setting up a national health ecosystem on a digitalized level, we have a concerns of data privacy there. If the data privacy of an individual, especially the health data leaks, then it may be a big trouble and it may be a big chance for the insurance company to grab in the corporate markets also. So ma'am, how can we address this issue and we can protect the privacy of an individual, especially the health data?
So I would like to say to you 2 things. One is, this mission is not just about health records, okay? There is a national digital health blueprint that we released in 2019. It is available online. Have a look at it. Then you will get, it's the whole architecture. So there is, disease surveillance. There is, teleconsultation. Everything is sort of thought about and architecture is defined. And at the center of this architecture is a consent framework. Okay, without your consent, nobody can transfer your data. And security concerns. You remember when we initially started Aadhaar or initially started DigiLocker, there were so many concerns for privacy. Now they are not, isn't it? Even for digital payments, among some, we are banking online, isn't it? There are frauds, but it's not as if it is deterring us. There is also, safety nets for that. So the concern, I'm very happy, is being articulated and articulated very vocally. So the privacy framework and consent framework is critical and crucial to this, I would say, ABHA as they call it, making those individual records available. Next is that the data privacy law is actually in the parliament. It is now being looked at by a parliamentary subcommittee. So I'm sure with its passing, the privacy aspects will be strengthened. So I think we need to be cautious, but we need not fear. That is what I would say. The government is seized of it, and there is a lot of innovation also going on. So the rollout of, or say the, lots of private hospitals are also getting in. But you are right that there is this danger of exploitative, of exploitation, especially by, even this data of communicable diseases, say NCDs. कोई जाकर बोले कोई फार्मा कंपनी कि आप तो प्री डायबिटिक आप दवाई शुरू कर दीजिए. You see, but this data is again housed in, say, public domain. With the state governments in NIC, and it's not shared with anybody except, for information, the numbers. So MIS is different from line listing of this data. So those concerns have been addressed. But this is a work in progress, I would say.
Indeed, ma'am. Ma'am, now I would like to ask one question, slightly digressing from the topic. Ma'am, recently we have seen a NEET row in which we have seen that we have witnessed the outcome of artificially constrained supply of medical seats. Ma'am, our students are going to study medical education from Russia, Ukraine and China, etc. countries. Ma'am, PM Modi has also urged the private sector to open up the medical colleges so that Indian students can study in India only. But ma'am, we have seen that private education is heavily expensive in India. So how would this address the issue of expensive medical education?
So we presently have about 542 medical colleges, both private and government. Okay. First of all, I would like to say that recent years, from 2014, in fact during my tenure itself, 157 new medical colleges have been sanctioned in the public sector, okay, government. Then there is also one initiative of setting up medical college in every district, linking it to the district hospital. Then you have spoken about affordable medical education. So right now the arrangement is that every hospital, every private hospital has to give certain amount of seats to the state and to the central quota where the government rates apply. Rest of it they do what they want to do. But you are right, we need to actually monitor that, we need to have a regulation for that. Now, you may have seen in the newspapers that the new medical commission is talking about it, and there was a lot of resistance also. You may have read that also from private hospitals saying that a hospital takes, crores to set up. How, if you will regulate our fees, how will we set up new hospitals? You know, there is argument on both sides. But now also, see, I feel that our thrust on infrastructure was actually little unbalanced. कि भाई आपको 20 एकड़ ज़मीन ही चाहिए या इतनी buildings चाहिए इतना वो, that also is being predefined or that also is being redefined by the National Medical Council. So the government sees that the private medical colleges need to bring down the costs, and 2-3 ways of doing it is, as I said, the criteria for setting up of medical colleges is being relooked, number one. Number two, regulatory systems are also being sort of tweaked, and consultations with private colleges are actually going on. And as far as seats is concerned, there has been a 33% increase in PG seats and about, I think, another 25% or more in the recent years. And with setting up of these new institutions, you know, 22 new AIMS are coming up. So that all, I think in the next decade you will see a lot of change. But you must remember that our population also is huge. So it's not that we can meet everybody's aspirations, but it's work in progress.
But this issue, ma'am, as you have said, as a youth population, we have seen that the medical has completely gone corporate here. It is a vast profit-motivated business. The use of standardized medicines, the use of the unwanted diagnosis in medical sector. We have seen this. Recent data from Kerala, I guess from South State, has seen that around 12% deliveries in government hospitals are cesarean, while around 90% deliveries in private hospitals goes to cesarean delivery. So this unwanted and unethical practices in medical sectors has led to this, are the generation of this vast monetary expenses that these medical students pay for their medical education. So regularization is one thing, and how about the subsidize the medical education for this thing by the government?
So see, it's not just subsidizing medical education, it is also ethical practices by the doctors. Okay, though every doctor takes this Hippocratic oath, but I don't know how many actually implement it, number one. Number two, you are right that, for example, cesareans in public sector are only 12%, but in private go up to 75%. Why should that be? So, you see, now the point is that the public sector maternity facilities are being expanded, number one. Number two, it is also many times that, you know, a woman goes in distress and she doesn't know that she can deliver, and they also don't want to wait because bed khali ho jayega, you know, sometimes it takes 2 to 3 days also for some women to deliver. So it's also you know, fast work, and it is also higher fees that these two I think propel people to do cesareans in the private mode. But you see, now we are linking each pregnant woman with, say, messages going, especially in the rural areas. Again, in urban areas we need to do more, that you need to have 4 ANCs, that means you know, antenatal checkups. तो उससे तुम्हारा complicated है या नहीं? Because women don't know, you see, they don't know कि भाई मुझे cesarean करवाना ही पड़ेगा. अगर बच्चा वैसे ही ठीक है, तो why should you? And in that ANC, they are also told, have you taken tetanus? How is the child growing? Are you eating properly? Is your nutrition intake better? Or the bacha underweight na ho? So all that is also being done through health and wellness centers also. So that should make a difference. But again, when we come to fees regulation, then I would say that we need a good regulatory framework by the states. There is something called, you know, there is an act, clinical, sorry, I'm forgetting the exact name, clinical management, so sorry, it is basically a model act which has been, if I remember, if you allow me to Google, I'll Google and tell you. It's a, it is an act, it is a model act which is framed by Government of India for the states to follow as per their customized needs to regulate private hospitals. Okay, so Karnataka has done a good job of it. Some states are, Haryana recently has actually adopted that. So once it is done, then there is an authority to actually look into the fee structure of private hospitals to ensure reporting. Another thing I want to share with you, IT will make a lot of difference. You know, there is this association of small clinics in Mumbai which put on the net their outcomes. That a patient has come, how many cesarean, how many natural, how many days they stayed in the hospital, did they die or did they sort of, and what is the re-hospitalization. So that way, if each hospital is bound to do it, it is mandatory for each hospital, then people will also know ki bhai yahan jaye ya yahan na jaye. So that's what actually I have been also advocating to QCI and all this Quality Council of India, is that we must sort of ensure that online the outcomes of every hospital and big hospitals, 50 beds and above should be actually available for citizens. That will also increase accountability.
Thank you, ma'am. Ma'am, I have a question on the retention of medical talent. Ma'am, at Compass 2022, when Dr. Swaminathan, Chief Scientist at WHO, was asked about brain drain, she said that rather than focusing on brain drain, we should focus on brain gain, or reverse brain drain as many call it, a term I'm not quite fond of. That is creating attractive opportunities of inviting doctors who leave India back to their home country. Ma'am, how do you think this can be made possible?
Okay, I am now sort of, it is in my mind, I asked one of you ke Google karke batao wo clinical, that is an act to regulate private hospitals, uska kya naam hai? Please do it for me and tell me. Okay, now see, brain drain. Okay, yes, actually National Health NHS system in UK is actually run by Indian doctors. Okay, we have lots going abroad also. I think there should be no bar because India believes in, you know, free movement of its citizens. Number one. Number two, reverse brain drain. Actually, you will be surprised that people are coming back. They are coming back, which is a great thing. And we are also facilitating in a number of ways, in the sense that, for example, let me tell you a simple case of health and wellness centers. We have made a provision for voluntary service by a NRI doctor who comes and stays in his village for 2 months or 3 months. आते हैं ना लोग वापस अपने parents को मिलने, 1 महीना तो रहते हैं. They can volunteer in the health and wellness center. There is a form for that. And next is that now we are 22 AIMS are coming up. We need faculty for it. And actually, this is one, I have found that some of the doctors abroad are actually now applying. Because they are also looking for an opportunity to give highest quality of service, you know, in the tertiary care. So I'm sure that this will sort of become a trend. And also I think the brain drain also has slowed down. Now there is a disillusionment with most of the countries. I mean, if you see, you had a session on foreign policy, you have seen the world is changing actually. You've seen US conditions kaisi hai, UK mein kaisa hai. So people are actually coming back, or people are also sort of, now the opportunities are more here. 157 medical colleges, where will we have you know, faculty if our own doctors don't work there? So it's also creating an ecosystem for satisfying work and good remuneration. So that both things are happening.
And here Clinical Establishment Registration and Regulation Act of 2010.
Yes, thank you so much. because otherwise it would have been yaad nahi aa raha. So that's the model act to regulate private hospitals, which some states have adopted. The states also can actually customize it. So this is what we need. And from Government of India, we keep writing to them. I myself remember writing to them at least 3-4 times.
Thank you, ma'am. Ma'am, here again I want to digress on a topic of women's health. Ma'am, here I want to quote Michelle Obama's quote that communities and countries and ultimately the world are only as strong as the health of their women. Ma'am, a report from ICMR in 2018 reveals that 50% of Indian women suffering from anemia. What measures do you suggest to ameliorate the situation of
That is why our maternal indicators have also improved, IMR, MMR and all that. But women's health on a life cycle approach has been missing. So very true, and anemia, as you said, is a huge problem. And in 2019 we did start one drive for Anemia Mukt Bharat. So again, what are the ingredients? The ingredients are that, during pregnancy you have 4 ANCs, as I said. There you make sure that you take your iron pills along with your TT and all that. Then in the schools, because if the, okay, let me finish that pregnancy part first. Because if the mother is healthy, the child will be healthy. If the child is, and especially the girl child, if the girl child is underweight, then you see the anemia or the weakness or women's health, all those complications will start. Then in the schools also, dispensing what we call IFA, iron folic acid tablets, has been taking place. But there are issues there. Normally because the nutrition is not good enough, so children get diarrhea, and especially the girl child. So therefore, this iron supplementation has to actually go hand in hand with nutrition. That is why you have this nutrition mission and free midday meals, then in the Anganwadi hot cooked meals or free rations. So this is a issue which is huge. And also in our homes, are we feeding the girl child equally as we are feeding the male child? So it's a whole mindset. It's not only resources, but it's also a mindset. But as far as government is concerned, Anemia Mukt Bharat mein, there is this IFA supplementation. Under nutrition mission, there is this I would say the interventions which I mentioned to you. And during pregnancy, if the child is born healthy, then you see the trajectory of life cycle diseases will be less, is also proven. So nutrition of the mother, especially during pregnancy, is also very important.
Here I want to point out this thing. When I visited in the Anganwadi centers of the Rajasthan, I have visited to the core villages. I have seen that they are not provided even with the electricity. Where we are preparing the future of the nation, the students from I guess 0 to 6 years are being indulged in the Anganwadi centers. We don't have electricity and the basic system or basic infrastructure for them. So why our government, or I would say everyone, is paying so less heed to them, especially in Anganwadi or the primary education of the children?
So, very good point you raised, and I also want to say that health is everybody's concern. Health is multi-sectoral action. Health is sanitation, clean water, electricity availability. You, in the hospital, you imagine if you're in the middle of a cesarean or in the middle of a surgery, your electricity goes, what happens to the patient, isn't it? So therefore, this infrastructure and electricity, there was a program of the central government also to have electricity in every village. So it is actually now with the 15th Finance Commission, the grants for local bodies has also gone up. So it actually also is the responsibility of the local bodies and the states that these infrastructure gaps need to be filled up. Because I am from Haryana and adjoining Rajasthan, of course it's a smaller state, but way back I would say in the 90s itself, electricity was a priority. So Rajasthan also I'm sure now would be taking action, but yes, your point is very well noted. Let me tell you that, we have been talking about this telemedicine and all. If you don't have cable network, if you don't have electricity, तो कहाँ से telemedicine करोगे? So therefore, from Government of India side, again laying of cable network, laying of electricity is actually being emphasized. And I hope these lessons of COVID now wake up our states also, that we should and we must ensure that electricity is available in public institutions.
Ma'am, when you spoke about electricity going off during a pregnancy, during delivery, I was reminded of that scene from Three Idiots, when they're delivering the baby and the electricity goes off and they have to get a vacuum cleaner to pull the baby out. So, well, yeah, we would never want to be in such a situation. Ma'am, with this, we come to the end of the session. Ma'am, we have one last question for you. Ma'am, what, in your view, are some of the measures that should be adopted in short, medium, and long run in the healthcare sector?
So, I would say it's not only for the government, it's for all of us. So in the short run, make sure that you eat right, you believe in Fit India, and you believe in wellness. Because if we take care of ourselves, we don't fall ill. Next is that in the villages, communitization of health and wellness centers, accountability of health and wellness centers. So there are these Jan Arogya Samitis which are coming up now, which will actually, जो जुड़ेंगी in health and wellness centers से social audit भी होगा. So as communities, we must ensure that our facilities are accountable. It actually depends on us. If we have a proactive engagement, then so shall it be. So in the short run, whatever facilities we have, they have to function well, isn't it? Wherever you need tweaking, you need to do it. In the long run, we need resilient health systems. When we say resilient, it means they adapt to emergencies, they adapt to normal times, they are comprehensive, they are also promotive, preventive and curative, they give good quality. And also there is a feedback mechanism. Because if you think कि हमने कर दिया यहाँ पे बैठ के कोई feedback नहीं लिया, then because it's always work in progress, because health is such a sector. And next is that we must use technology wisely, because technology is not our master, it's our medium. So we need to use it wisely. So this is what I would say should be our focus.
Thank you for the session, ma'am. Now moving to the second and the end part of the session. I believe that our audience may have some question from ma'am. So with your permission, ma'am, if anyone of you have any questions, then please raise your hands.
Thank you, ma'am, for the insightful session. I have one question for you. So, with the spread of COVID-19 pandemic, there has been a manifold increase in the demand for all India medical services. I would like to know your take on that.
So, should I share? This was one of the most frustrating aspects of my 3-year tenure. It is since actually now 3 decades that All India Medical Service is being discussed. And you would be surprised that there was also a bill which was actually put in the parliament. But there was so much opposition from the states on this that it didn't come through. And I'm hoping and I'm praying that, this All India Medical Service does come into being, because I think it is required. Though of course there are people who think that, you see, a doctor gives a personalized service. So language and his being local, his being from that state also makes a difference. But we have seen that in All India Medical Institutes, in medical colleges, you have doctors from all the states. And they are doing a wonderful job. So therefore, in my personal view, this service should come into being, and we hope that this lesson of COVID has taught us that all the, I would say, political parties and the states, they have a consensus. The Centre has floated that idea once again. Thank you.
Thank you, ma'am. With this, we come to the end of this session, moving the needed post-pandemic reforms health sector in India. I, on the behalf of Caucus and Hindu College, would like to express our gratitude for ma'am to accept our invitation and join us here at campus and making it a grand success. Now, I would like to hand over the mic to the host.
Thank you, ma'am, for such an insightful session. Now I would like to invite the President of Caucus Society, Tanishq Gedam, to felicitate ma'am. Thank you, ma'am.